Thank you for joining us tonight for the program, Understanding Supportive Care, What Every Caregiver Needs to Know. I'm Andrew, and I'm joined by my co-facilitator, Colleen, and we head the Caregiver Support Group. We're so appreciative that Dr. Esch is able to join us for this presentation and discussion today. The video and presentation will be recorded, but the discussion and Q&A will not be recorded. The recording will be available on the SHARE website in 1 to 2 weeks. Feel free to submit questions through the chat feature during the presentation. Andrew Esch is a palliative care specialist focusing on improving the quality of life for patients and families living with serious illness. He earned his medical degree from the University of Buffalo, where he also earned a combined Bachelor of Science and Master of Business Administration degree. Before becoming the Senior Education Advisor at the Center to Advance Palliative Care, or CAPC, Dr. Esch was a CAPC consultant and faculty member. Prior to joining CAPC, Dr. Esch was the medical director of palliative care at the Lee Memorial Health System in Fort Myers, Florida. During his time there, he was recognized with the prestigious Phoenix Award for his work with people living with cancer. Dr. Esch speaks nationally on palliative care education and growth and sustainability of palliative care programs. And it's my great pleasure to turn the floor over to Dr. Esch.
Thank you, Andrew. Thank you for having me. Is my screen up? Can everybody see the slides? Okay, great. It's really my honor to be here tonight. There's nothing more I've enjoyed in my career than talking to patients and caregivers. And as part of my work with the Center to Advance Palliative Care, I get to do that pretty regularly. So tonight I was asked to kind of cover some specific material, but what I'd like to ask is if you're comfortable using the chat feature, maybe just type a few words or a sentence about what you were hoping to learn tonight. Because I want us by 7 o'clock to feel like this hour was valuable to you, that you got what you needed out of it. And while I have maybe 15, 20 slides, I think that I'm going to run through that sort of give some background on understanding supportive care and the differences between hospice and palliative care, I really want to get to what's important to you all too. So if it's not too much, maybe you could just drop that in the chat box. And I can't see it right now because my screen's full of my presentation, but I'll look as soon as we get through this formal part. Does that sound fair? I try not to do too much in a 1 hour talk because I just think the real magic happens in the question and answer session. That's when you really get to what's on people's minds. So we're just going to talk about what hospice is. We're going to talk about what palliative care is, and then we're going to answer your questions. And then I'm going to point you in the direction of a website that I think is fantastic. And hopefully some of you at least are familiar with it already. But if you're not, if there's anything you take away from my talking to you for an hour tonight or being here with you tonight, is this website. It's just fantastic. Videos from cancer patients that are going through treatment, survivors, all the information you want to know on other illnesses and their relationship to palliative care. So there's quite a bit there for people that's really, really beneficial. So if anything you take away from tonight, I hope you remember that website, jot it down, and spend some time on it. And I just think it's the best place to go for patients and caregivers to find out more information on what they can do while they're being treated for their illness, cancer, illness, or otherwise. So I want to just do a couple background slides on what living with serious illness is like in the United States. And I know that seems funny because you are, you're close to it as close to it as possible. as caregivers, you know, watching a loved one or somebody close to you go through serious illness. But one of the things that is transforming in healthcare is this recognition that it's not enough to treat the disease. We need to treat the pain, the symptoms, and the stresses of these diseases, serious illnesses like cancer, and what happens after you're done with treatment, as just as important as treating the illness itself. So long gone are the days where, you know, you want the surgeon who just cuts straight and does a nice stitch at the end. Like you want your clinicians, you should expect your clinicians to be someone that is interested in what your experience of that illness is, of what your experience with cancer is. And, you know, that transformation is happening. It's not happening as fast as any of us would like, but it is. Because while, you know, we get trained to focus on curing and treating illness, cancers and other illnesses, but what patients worry about, or what patients struggle with, is worries, anxieties, symptoms, shortness of breath, fatigue, constipation. I guarantee everybody on this call has been fatigued at one point or another. I was telling the organizers earlier, I'm a melanoma survivor, and you know, there was weeks and weeks, if not months, where, you know, even after treatment and surgery, like it's exhausting. So fatigue is common. Stress, you know, financial stress, just stress of like interpersonal relationships. People change when you get a diagnosis of cancer or somebody you love does. So, you know, those things change. Neuropathies, you know, that tingling pain in the feet, things like that you get with treatment and other things. All of these things are what we are struggling with as patients and caregivers, not just the illness itself. So, you know, there's a lot more to it than just the illness. And, you know, it shouldn't be as complicated as we've made it in this country. Because it's not complicated. When serious illnesses like cancer strike, I want to be cured. Like when I had melanoma, I wanted to be cured, or I wanted the disease kept in check. I wanted to also maintain my function. I wanted to keep working. I wanted a decent quality of life. I wanted to be coordinated and connected to my care team. And I wanted to support to make good decisions about, you know, do I do adjuvant chemotherapy or do I just do surgery? Like I needed people to talk me through that. And I'm a physician and I knew a lot of this stuff. But when you're the patient or you're the caregiver, the whole thing changes. I mean, you really need somebody to shepherd you through this. And how well do we do that as a healthcare system? And the answer is not very well. Usually, I'm hoping that in the Q&A, you tell me how wrong I am about this and that things have been excellent for you. But my suspicion is, my hunch is that's not what I'm going to hear, that we still have a long way to go. Because we're driven by illness. We are a sick care, very technologically driven, disease-driven system that really shortchanges talking about quality of life. And the reason for this is we don't get trained to talk to patients. You'd think we would in medical school, but we don't. And so we have to learn this as we grow in our careers, because, you know, we're not trained to talk to patients about their illness. We don't get pain management training very much in medical school. Nobody ever taught me how to treat nausea, vomiting, or fatigue. I had to learn that on my own. And so when it comes to people and caregivers that are living with serious illness, the things that are on your mind the most are the things that we get the least training in. And so, you know, that creates a gap that I think every patient and every caregiver has sensed as they've traveled through our healthcare system. And we need to do better. I mean, it's just unacceptable. So that's what we're working on. I mean, I do think as a healthcare system, those of us in the thick of it, us, the clinicians, want these skills. We need these skills, and we're doing our best to get them. You know, we need to put you guys in, for me, when I was the patient, at the center of care. We need to move to more person-centered care. We need to recognize health problems as you guys see them. And we need to focus on the whole person, including the caregivers in the unit of care. I'll be really curious in the Q&A, and I'll probably ask a few of you if any of the clinicians you've ever had have actually sat down and asked you as a caregiver how you're doing, how you're feeling. What is it like to give all those unpaid hours of care at your own health consequence, at your own financial consequence, probably. I mean, there's just so much that goes into caregiving. It's you guys are the unsung heroes in all this. And I'm just curious how many times that's recognized. And we just need to recognize the needs of patients and caregivers, and do a better job of not just recognizing them, but addressing them over time. So thank you for indulging me on that little trip down our horrific health system. But I think I want to message a little bit of hope that we recognize the issues, we're working on them, but it's like turning a huge ship, right? It's just going to take time. So we're working on it. I'm hoping that it's better soon. So how do we make all this happen? Well, that's what drew me to palliative care. When people say, like, why did you go into palliative care, doc? Like, I say, because it allows me to be the kind of physician that I promised I would be on my med school application essays. I wanted to take care of people in a way that was meaningful. And so to me, palliative care answered that for me as a specialist, because it's specialized medical care for people living with cancer and other serious illnesses that really focuses not just on the disease itself, but what the experience of living with that disease is. And our primary goal is to improve quality of life for both the patient and the family or caregiver. And it's provided by a team, which was so cool to be working with nurses, social workers, chaplains, and we work together to provide an extra layer of support to patients and families who are also getting curative treatments, disease-targeted treatments. And if you think about it, all the stuff that you've experienced as caregivers, patients living with a serious illness, to think that there's one clinician that's qualified to meet all of your needs emotionally, spiritually, physically, like, I'm pretty good at what I do, but I can't do all that. I do need a team. And so that's what I love about palliative care, is the team-based approach to it. And it's also appropriate at any age or any stage. Like, you don't have to be super advanced in illness. I always tell everybody the best day to get involved with palliative care is the day after you're diagnosed with something like cancer or a serious illness. And the reason for that is we deserve the best, right? Like, when I was sick, I wanted the best of what medicine had to offer in terms of cure, but I also wanted the best of what my field offers in palliative care to provide me with the best quality of life. And why shouldn't we all have that? Like, they both exist. High quality palliative care exists and great disease targeted treatment exists. Why shouldn't we all have both? And the ultimate goal is providing those dealing with serious illness the best of what medicine has to offer in terms of cure and disease-targeted treatment, and what we have to offer in palliative care to improve quality of life and make it the best that it possibly can be. Oops. And one of the things that was a bit shocking to me, we've done research. We've done this research in 2011 at the Center to Advance Palliative Care, and we've actually updated it, and the stats aren't all that different. People really don't know what palliative care is. We surveyed 800 adults age 18 plus, and we asked them, hey, what do you know about palliative care? Like, I mean, 97%, or I'm sorry, 92% really had no knowledge at all, didn't even know what we were talking about, or claimed to have some knowledge. That's pretty low, right? Like, if I asked you what cardiology does, I think everybody here could tell me, right? So my field, nobody knows we exist usually. And then when we name it, nobody knows what we do. And so that's, we have some work to do as well. But what we did in that survey group is we gave them a definition of palliative care. The definition, I'm going to paraphrase here, is this. It's an extra layer of support to be given along with other curative treatments to improve quality of life for patients living with serious illness. And when we use that very simplistic definition, people had really positive attitudes about it. 92% said they would consider it. 92% believe they should have access to it. And 95% said that patient and caregiver and family education regarding palliative care as part of a treatment plan is important. So you don't know what it is, you get told what it is, and you feel pretty good about it. Seems like we were on the right track, right? Because what we do is we help relieve pain and symptoms. There's actually studies. There was a study in the New England Journal of Medicine. It's a little bit older now. It was in the early 2010s, like around 2012, 2013, that there were lung cancer patients that got traditional care and then the traditional oncologic care with palliative care. And that group lived longer than the patients that didn't get palliative care. I can tell you what my theories are about that if you want in the Q&A, but the data was there and it was statistically significant. It was real data. We offer better family support. We have a team of people that not just worry about the patient, but we worry about caregivers. We talk to our caregivers. We link them with resources in the community like yours if they're interested and need or want that. And on the business side, we keep people out of hospitals and emergency departments. So yeah, financially, great. But for patients and caregivers, you don't want to be in the ER. You don't want to be in the hospital either most times, right? If something really bad's happening or you're really suffering, maybe the hospital is a place for relief, but most times we don't want to be there. And we reduce unnecessary tests and procedures. I don't know about you, but I'm no longer any good with needles. Like, it's just, there's a lot of blood drawing going on. And, after a little bit of that trauma, living through what I lived through, I'll be happy if I don't see a needle again for a long time. So, trying to reduce the amount of things that get done to us, I think, is important. We really just want to see the person beyond the disease. The American Cancer Society a few years back had a great ad campaign. This is one of my favorites. And I just, even when I teach residents, medical students, and others in my travels, it just is no longer acceptable to say, oh, it's the lung cancer patient in room whatever, or the ovarian patients there. Like, I want to know their name. I want to know what they do for a living. I want to know what they identify as, because I guarantee we don't identify as our diagnoses. We identify as what's important to us, right? And that's at the heart of what palliative care tries to do for patients and caregivers, is bring that humanity back in addition to all the other curative stuff that's going on as well. So that's palliative care. You can get it on day of diagnosis. It really can be done with all your other treatments. It should be done with all your treatments. I don't know. There's no quality of life without life. I want you all living as long as possible. I want to live as long as possible. I just want to do it with a high quality of life. So if there's treatments out there for you, fantastic. I want you to get those. I just don't want you to suffer or be miserable with side effects of treatment or symptoms from your illness. I just think we can do better. And that's what palliative care does. So what's hospice then? Well, hospice, the palliative care field was born out of the hospice model. It's just hospice, you have to be basically dying, like a prognosis of 6 months or less to get it. But the principles are very similar. It's about quality of life and treating symptoms and making sure people are as comfortable as possible. But to qualify for hospice care, there's some general requirements. You have to have a life-limiting illness. Your prognosis is 6 months or less. If the disease takes its normal course, you need to live in the service area of the hospice that you're talking to. You need to sign a consent saying that you're going to allow your insurance to switch over to hospice. I'll talk about that a little bit more. And a lot of hospices will make you forego other medical interventions for your terminal illness. Some will allow you to continue some chemotherapies in that, but for the most part, this is at the point where you've either tired of treatment or treatment's no longer effective, and you're looking to just really manage your symptoms and focus on quality of life. And what's kind of neat about hospice is that it's above anything else, it really is an insurance benefit. It gives your insurance company the ability to pay the hospice for an entire range of services that you're going to need to be in your home and taken care of in the way you should be. Case management, the medications, if you need a hospital bed or a chair or a walker or a commode or chair rails or whatever it is, durable medical equipment like that is part of those services. Any supplies, bandages, tape, things like that, volunteers, grief support, nursing visits, nurses' aid visits, physician visits. All of this is provided in, like a hospice will pay, or your insurance will pay hospice, I'll just use $150 a day. And within that bundle of money that they get from the insurance to take care of you, they have to supply all these things. And these things add up pretty quick. So it's a great deal for patients and families financially. It's also an amazing deal for them in terms of the amount of services and range of services they get at a time when they need them more than ever, right? And so I stole this from the National Hospice Palliative Care Organization. They're called the NHPCO. It's sort of a trade, like for us clinicians, it's a trade organization. But I mean, I think I'm more visual than I am reading slides. But like, this is so good. The patient and caregiver are the center of it, right? and everybody else is working around as a team to meet your needs. So where is it provided? One of the biggest things I hear when I get patients and caregivers talking to me about hospice is they think it's a destination. Hospice can be a destination, but hospice really is an insurance benefit more than anything else. Most hospice takes place in the patient's homes. It can be in other facilities too, but the majority happens in the home and provides all those services we talked about. It's paid for by insurances, sometimes a combination of insurances, but it's an insurance benefit. And so, you know, hospice lasts 6 months of life, right? A bunch of bundled services are all covered on a per diem rate that's paid by the insurance company. And the hospice needs to provide all those things to patients and families, no matter where they are. If they're in the home, if they're in a nursing facility, wherever it may be. So a little bit of just wrap up slides. I love the 2 sentences in bold. Palliative care is based on need, not prognosis. You don't have to be dying to get palliative care. In fact, the most effective palliative care is when it's done earlier in a disease course. It's available from the time of diagnosis, focuses on comfort and quality of life, along with other curative and life-prolonging treatments. Hospice is based on prognosis. Patients are expected to die in the next 6 months if things go their normal course. And it focuses on comfort and quality of life when cure is not possible with specialized care and services. So I know this is nuanced, but just if you remember that palliative care is based on need, if you're suffering, please think of palliative care. We can help. And if you're pretty advanced in your illness and your prognosis is 6 months or less, or somebody has talked to you about hospice, I would encourage you to listen, because we're not, us bringing up the word hospice is not what got you to that point. It was the illness that got you to the point. But there's so much help that can be given by hospice services that to forego that based on fear, I think, I just wish I had a better way of talking about it so that I could just get rid of all that fear that people have when they hear that word. Because in that last 6 months of life, there's nothing that even touches what you can get through the hospice benefit. I created this chart, and my understanding is that these slides will live on the website. So I like this slide. Again, I'm visual. I like side-by-sides. You know, and this sort of summarizes everything that we've talked about tonight. When can you have it? You have to be pretty advanced in your illness to get hospice. You can get palliative care anytime. Who provides it? Both are provided by teams. I will say hospice teams are usually a little bit better staffed than a lot of palliative care teams. We lose money in palliative care. It usually takes a hospital or a health system to subsidize us because we can't bill insurance enough to really cover the whole team. I'm the only person on my palliative care team that can submit a bill to your insurance. So me submitting a bill to pay for a social worker, a chaplain, a nurse, and all the other stuff is just, the math doesn't work, but there's value in it that goes so far beyond the reimbursement that we do it anyway. So each are done by a team. Palliative care teams, generally speaking, might be a little smaller because we don't have the financial resources hospice does, but they're still small but mighty. So can you do it concurrent with your disease treatments? Hospice, generally speaking, no. Palliative care, yes. Who pays for it? Hospice is that special insurance benefit. For palliative care, we bill in your insurance like any other doc would. Where can you have it? Pretty much anywhere is the answer for both. And what's provided? A team of specialists in both. There's more variability in the makeup of the team in palliative care just because the financial reimbursement is not as rich as it is with hospice. I covered a lot there quick, but I wanted to get to Q&A. Again, here's the website. I apologize. My dogs get excited when I talk about this, I guess. Hopefully they'll calm down soon, but getpalliativecare.org, great website. And just burn that into your memory and go there and spend a little bit of time. So with that, I'm going to go to questions and I'm going to stop my screen share so I can see faces if that's okay.